Good morning. Good morning. Oh, you guys, so good to see all of you and everybody out there. I'm just so grateful that we're able to find this time to get together. I'm sure you've seen we've got a lot on the agenda. And again, I'll stress, this is about interactive, getting people here that are really topical in terms of some of the issues that we're dealing with, for you to have an opportunity to make comments, ask questions about the work that you're doing and how it relates to the boots on the ground experiences of providers, of facilities, of individuals that we're serving. So I certainly want to hear your thoughts and feedback and your ideas. And today we've got some great folks coming in to talk about several issues that I know many of you have been dealing with. But before we dive in, I want to highlight a survey, yet another one, coming your way. This is an employee satisfaction survey. And it's really important that we hear from you, that you take the time. I am very interested to understand, what are we doing well and where do we have greater opportunities to improve? So it's not a fishing exercise. When you see that survey, I need you to click on the link. So you'll get an email from me just reminding you that it's coming your way. And then from our human resources team, you'll be getting that survey. We're trying to incentivize, so you'll see for the bureaus with the highest response rate. I think, what are we looking for, John? 90% response rate, which I know is aspirational, but really important that we get a comprehensive response rate to inform what we need to be focused on throughout the year. So with that, I want to kick this off with a presentation. You all have been hearing about behavioral analysis, BA, lots of discussion at the legislature and in the media, and so I'm so grateful that we have Christy Roweather here from the Florida Autism Center. She is the CEO and is going to talk to us a little bit more about the work that they do, some of the issues that have surfaced around this, and then again be available for questions from all of you. So Christy, welcome. Thank you for joining us today.
Madam Secretary, thank you so much for allowing us to be here today. We're very excited to have the opportunity to speak with you about what we do. Have any of you not heard about Provider Type 39 over the last 6 or so months? That's a joke. Okay, as mentioned, I am the CEO of Florida Autism Center. My name is Christy Roweather, and I am joined today by my colleague, Jessica Cloutier, who will also be speaking. She is our VP of Client Experience. So I'd like to kick it off first by telling you a little bit about Florida Autism Center. I found the clicker. Aha. Okay, Florida Autism Center, we are Provider Type 39. We provide center-based ABA therapy. We were founded in 2005 by a BCBA named Kristen Bullock. We are located in Lake Mary, Florida, and we have about 31 centers throughout the state of Florida. Our typical footprint of a center is about 4,000 to 6,000 square feet. We have about 10 to 15 therapy rooms per center. We primarily focus on early intervention. Early intervention is categorized as ages 1 to 4. We really like to help children early because we see better progress when we can get to them earlier. We provide group therapy, direct social skills. Some of our kiddos, as a term that you will commonly hear in the world of ABA is kiddos. Coming from a nursing background, I am a registered nurse. I was used to them being called patients, but in the world of ABA, you will hear them called kiddos, and that is normal. And we provide parent training because it's very important that our parents are able to transfer the skills that we teach their children in the centers to the home base so they can continue to progress. Being a registered nurse, it's really important to me and our company that we are providing quality services. So we like to pride ourselves in being best in class. And as we all know, ABA is becoming more and more regulated. And I always tell my team, we want to be the trailblazer in this industry. As a result of that, we have a BCBA, board certified behavioral analyst, who is doctoral level, as our chief clinical officer, as well as our chief compliance officer is a registered nurse who also is an attorney who has about 25 years of healthcare experience. So she helps us all sleep well at night. See if I can get this to work. Oops. Too fast. Okay. What is autism? A little bit about autism. Autism is classified as a developmental disability, and oftentimes we see children struggling with language, their communication, social skills. Children don't interact. They don't want to make eye contact. Sometimes on the playground, when everybody is interacting, oftentimes children on the spectrum are far off in the distance, kind of away from everyone else. They like to be alone. And then we see behavioral challenges, which is what we pride ourselves on, is improving those behaviors. Statistically, 1 in 59 children are diagnosed with autism today. If we look back 10 years ago, the statistics showed that 1 in 125 children were diagnosed with autism. 2 years ago, it was 1 in 68. So we all know the prevalence is increasing, and therefore there's a continued need for ABA services. And you're seeing lots of providers in Florida as a result of this. And you'll hear it called spectrum, ASD, autism spectrum disorder, because there's a wide range. Sometimes we have kids who are considered gifted, while other times we have severely challenged behaviors that we're dealing with as well. And then just some common signs and symptoms of ASD. You may have heard of these before, but it's difficulty with that communication, again, both expressing themselves as well as being able to understand what's being asked of them as well. Difficulty with identifying objects in the environment, and Jessica will speak to some of the specifics of that shortly. Again, not wanting to make eye contact. And then difficulty adapting to routine. And then oftentimes you'll see repetitive behaviors as well. How is autism diagnosed? So autism is diagnosed by a professional diagnostician. Oftentimes this is a psychologist, a psychiatrist, a developmental pediatrician, or a neurologist. One thing autism cannot be diagnosed is, or one way autism cannot be diagnosed is by scanning or having blood work or any other medical test. It has to be diagnosed by one of these 4 providers. We see children diagnosed as early as 18 months. Typically, we'll see children diagnosed around that 2-year mark, but as early as 18 months, we've been able to provide services for children. And then the treatment, there is no cure for autism, so early intervention is key, and the ABA services that we provide. And this is where ABA comes in. So as you'll see here, applied behavioral analysis, it's a method of systemically bringing about positive behavioral changes in children, and it's the only scientifically proven therapy that works. And I mentioned earlier that it's not only for children on the spectrum, but it could be for children with a variety of developmental disabilities as well. So the goal is to increase appropriate behaviors and decrease the inappropriate behaviors. And then, as you all are well aware, I believe, autism or ABA therapy can be provided in the center, it can be provided in the school, or it can be provided at home. So why is ABA important to children? First and foremost, it works. I can tell you that I have witnessed so many success stories in my career here during the 3 years I've been here. It works. ABA works. And the children, they make progress. The families are able to have a sense of normalcy at home, and it helps the children become productive members of society. So if we look at the appropriate treatment, without appropriate treatment, we're looking at a cost of about $3.2 million. And that is a proven research statistic because these children will require special education, adult services, and again, they'll have decreased productivity. So with ABA therapy, there's an estimated lifetime cost saving of about $1 million. So ABA therapy is administered by a BCBA, the board certified behavior analyst again, as well as a registered behavior technician. And this shows the profile of a BCBA. They're board certified, and essentially they evaluate and provide the treatment plan for the child. And then the registered behavior therapist, who in our world, in the world of Florida Autism Center, they have a college degree or at least some college alongside their 40-hour requirement. They are what we say the volume driver. They're providing the on-the-boots delivery of services. Not on the boots, but boots on the ground delivery of services, sorry. Okay. And Jessica is going to tell you a little bit about what ABA therapy entails.
All right, to start off, so she's talked a little bit about what we're teaching. One of the most important things about ABA is individualized. So every kiddo is going to come in, receive an assessment, and then their plan is going to be structured specifically to them. We're going to look at the skills that they are weakest in, those challenging behaviors. We're also going to look at what are those replacement behaviors. So children are engaging in aggression, SIB, elopement, and then we're going to find out, typically there's a function of why they're doing it, and how do we replace skills so that they can gain access to the things they need without engaging in aggression or self-injury. So each of these kids are going to come in and we're going to provide an individualized plan. A BCBA develops that plan through their assessment. They're going to spend a lot of time with the parents. They're going to find out what's important for the parents, what's needed at home, and then develop that plan. And then the RBTs are the ones that are going to implement it day to day. The next important thing, and what you'll see in any real quality ABA program, is that we're collecting data continuously. So at FAC, all of our RBTs are taking electronic data throughout their entire session. So we are tracking the number of times they become aggressive, or tracking the number of times that they can request an item, whatever programs we're working on. And then the BCBAs are coming in weekly to evaluate that progress. We're graphing all of it. We're seeing what's working and what's not, so that very quickly we can address the programs so that we're seeing progress. If something's not working, we want to jump in very quickly and not go 3 months of trying something that wasn't working. So just a little more on the kind of things that we're going to work on. With those new little ones that we're getting in the door that are maybe 18 months, 2 years old, the first few things that we're going to work on is teaching them how to learn. So children on the spectrum very often have no imitation skills. So if you watch a typically developing 2-year-old, they are going to watch mom bake a cake and they're going to pretend. They're going to get bowls out from under the cabinet, they're going to stir, they're going to pretend to shave like daddy does in the mirror. Kids on the spectrum do not pick that up. As kids develop and get older in school, you watch the teacher at the board and you imitate that in the classroom. So those are the first skills we're going to start with kids. So you may walk into one of our therapy sessions and see a therapist saying, do this, do this. And those are the very early steps of imitation. From there, we then can go on and teach communication. We're going to typically start with what we call our MANs and teach the kids to ask for things. So often you'll find kids are aggressive or engaging in self-injurious behavior because they have no language. So as behavior analysts, we're going to start with what is the most desired item for these kiddos. So our kids may really enjoy bubbles or cookies. It's all going to be individualized, and we're going to start with that, whether it be verbal, sign, picture exchange. They may use a communication device. We're going to start to give them language, and likely when they build those skills, you'll start to see the other problem behaviors decrease. It's not always that simple, but that's typically where we'll start. So we're going to start with that communication, the ability to learn things, and as we build their skill set, then we will move into more things like self-help. Can they brush their own teeth? Can they dress themselves? We may go into toilet training if they aren't developing that as they typically would. Then we're also going to go into those social skills. Can they interact with peers? Are they able to ask their peers for items? Can they share toys? Things that they're going to need in a typically developing classroom so that we can prepare them to transition out. So Christy talked a little bit about early intervention. Studies have shown that the earlier you start and the more intensive you start, the likelier these kids are going to progress and be able to transition to a typically developing setting. So at FAC, that is our goal, to get them in young, really intensive behaviors, and hopefully transition them into a less restrictive setting by the time they're ready for kindergarten. That is not going to happen for all of the kids, but that is our goal. So a little bit about, if you spend any time with any behavior analyst, you'll hear the ABCs of behavior. So this is how we are going to evaluate what the function of the behavior is. So when a child's engaging in aggression, if they're engaging in self-injury, we're going to evaluate what's happening first, so the antecedent, what's happening right before the behavior. We're going to track what the behavior looks like, the B, so are they hitting, are they scratching, are they running out of the room, and then the consequence, so what's happening right after. And this is where we really get parents involved. We're going to ask them to track this data at home, because what we're going to find is typically what's happening after is somehow reinforcing the behavior. So think of, mom says, every time we go to the grocery store, when I walk up to pay for my groceries, Johnny falls on the floor and starts screaming, and I just can't get out of the grocery store. And you say, well, what usually happens? Oh, well, the lady at Publix brings him over a cookie. Every time. She sees me every time I'm in the store. Well, that's why. He's learned I fall on the floor, the lady brings me a cookie. So it's a simplified version. But then we're going to work with mom on either changing the antecedents. So then we will say, all right, before you walk up to the register, you're going to get him to say cookie. You're going to get him to ask for the cookie before he even engages in the behavior. And then you're going to strongly reinforce him with a cookie when he says cookie to alleviate that problem. So it's a simplified version, but that's where we're going to evaluate those ABCs of behavior analysis. And then kind of looking at what is a provider's role. So talked a lot about it's got to be individualized. So you're going to want it when you're looking at, is this a strong provider? They are going to not have cookie cutter plans. Every kid's plan is going to look a little different. They're going to have qualified staff. They should be doing a lot of staff training. It takes a lot for our RBTs to understand and be able to make decisions when their BCBA is not in the room with them. So it's not a do the 40-hour course and you're good to go on your own. And I think the other real big piece is they need to make sure they're using research-based plans. So we don't just have a bag that we randomly pick things out and say, let me try this, it might work. A strong behavior analyst is going to be going into the research and making sure that the plans they're choosing match what has already been documented and proven to be effective. And then really getting the parents involved. Christy talked a little bit about parent training for us. And while we are in a center-based program, we really want to ensure that all the skills we teach transfer to home. So we are requiring our parents to come in, we teach them about ABA, and then we train them on all of our behavior plans. So they are going to come in, we're going to model for them and demonstrate what we're doing. They're going to have to do it themselves. And then we also encourage them to go home and take data so that we can transfer those skills. It's also really important to collaborate with the schools, the other providers. You want to make sure that if the speech therapist is working with a communication device, we're using the same one, as not to confuse the child and to improve progress. And then I think the last important piece is, like we talked about, is that plan to transition the kiddo out. So very early, having an idea of where we think this kiddo is going to get, how long we think it's going to take to get them there, what steps it's going to take, and what that transition plan is going to look like. For some of our kiddos, it will be that transition into a mainstream classroom. Some of our kids, it will be transitioning them into more community settings, like day work programs and things like that, if they're not going to quite make that same progress.
Thank you. You can stay up here in case anybody has any questions on the.
Yeah, so let me just make a couple comments, and then I'm interested in hearing any reactions or questions. So, I think what was fantastic about your presentation, some of the terms around individualized treatment plans, the evidence-based protocols, the research, the compliance, the standardization of the training for your staff, the quality bar that you've set. And I think one of the challenges that we face in Medicaid in particular is it's a claims-driven environment for evaluating services, which you can't necessarily derive from claims some of the data that you're using to support your progress. At the end of the day, we're spending $28 billion a year on nearly 4 million Floridians, and the question we all have is, are they seeing improvements in their lives? Is their health better? And so what we're challenged by is, how do we evaluate quality? And so I think this has been really helpful to hear your day-to-day commitment to these kiddos. How would you advise, as we look at ways to measure progress and quality, given the limitations of claims data, what are some of your thoughts on that front?
Yeah. You want to take it on the clinical side?
Yeah, so one of the things we're implementing, and it's very early, is that we are doing across the board standardized tests on all of our kids and parents. So we will be tracking, and this one isn't new for us, but the VB map. We're doing a parental stress index that we will be doing yearly for each of our kiddos to make sure there's progress on that end, and then some other standardized psychological tests to make sure that the kids are progressing, not just in our data, because we're picking programs and we're tracking and graphing those, but on a more standardized approach. We're going to test all of the kids yearly and also test the parents on that parental stress index to make sure that there's progress across the board for all the kids.
And I think from my perspective too, some of the things that you're implementing already, I applaud you. The multidisciplinary team approach and keeping people engaged in the progress of the child, I think will be key go forward, because that way proactively on the authorization side, you can kind of control what's going through to the claim side. I think it's a better safeguard.
Thoughts or questions? Come on now, this has been such a hot topic. There we go.
I think it's, oh, if you'll recap her question for the audience. Sure, her question was where, if we have an idea of where the kiddos that are coming in our doors now are going to end up when they're 21 and out of this system. I think it's hard to predict, especially in the state, the kids didn't have this intensive of services beforehand. So previously, they were ending up on the med waiver and in group homes and adult day programming. Our hope and goal is that if we can get intensive programming, that more of them will transition into school programs, but I think it's a little early to say, data-wise, what that's going to do with this population.
But it's a great question, and it's one that, as we look at our work with the Agency for Persons with Disabilities and the data and analysis that we do in Medicaid, how do we make sure that we're looking out 2 and 5 years as children are not just that transition, but how do we engage children at younger ages to set expectations for what an independent life can look like with some supports, and changing the expectations of parents about what their child can actually achieve. That will make a big difference on what the demands are as they become adults. And so we are seeing more generational changes for individuals with intellectual and developmental disabilities, for adults with autism, about how they can be supported in the community, moving so far away from what we think about from decades ago in terms of institutionalized care. Erica, would you like to chime in at all? Or, I mean, you typically aren't at a loss for words on this subject.
Well,
I'm putting you on the spot. You really have no choice.
I guess I don't, but so I do.
Let me get you a microphone.
Why, thank you. Oh my gosh. So I do have a question for you guys, specifically about parents' compliance. How compliant are your parents with the program and tracking data at home, so you can see how they're performing?
In full transparency, it's pretty hit or miss. We have some parents who are very dedicated and they come to every parent training, and with our system, they actually can look at the graphs from home and will read the session notes that we write every day. And then we have others who it is like pulling teeth to get them to take the data in. So, I mean, I'd probably say 60, 70% are really engaged, and then there's that about 30% that we've really got to drag them in to participate.
Yeah.
But I wouldn't say it's
have a
just the
question.
Medicaid population. That's all of our families. I mean, it's.
Good, thank you.
Thanks, Erica. So, do we have another question?
Is there any generational statistics available for how many were diagnosed autistic in 1940 versus 2000? I mean, is the numbers increased or decreased?
Oh, definitely increasing. Yeah, so the question was, is there any statistic to support increased prevalence? Is that, okay. Just going back to what I said earlier, 10 years ago, it was 1 in every 125 children were diagnosed. Today, it's 1 in every 59. So statistically, yes, we're seeing an increase in the prevalence.
You know, and the challenge, I think, with this is always, is it greater awareness, or is there something different in terms of contributing factors that are leading to more children with autism? And I don't think the science or the research is settled. There's certainly a greater awareness
Yes.
And education. You've also seen changes in the definitions around the spectrum. That's continual, but I think, lots of debate about what is contributing to. I know we have a question way in the back. You are going to have to project.
Yeah, I
You want to recap?
Oh,
the
I'm
question?
sorry. So she asked if I thought the 30% of the families who weren't overly active in services may be on the spectrum themselves. I would say some of them, yes. Some of them, it's other mental health concerns. Some of it's just they're not involved. Part of what we try to do to break it down for the families is we do behavioral skills training. So it is I model it. So I'm going to use the words, but I'm going to model it. Then you're going to try it, then I'm going to give you feedback. So we try to avoid as much of the terminology and those pieces and more of a actual model hands-on, very similar to what we do with the kids.
All right, one more question.
I know that early intervention is key. Do you feel like even over time, the age of children who start the program is getting younger? Are you seeing a greater influx of that being recognized earlier? And I ask because I came from the side of, I worked with a partner agency for vocational rehabilitation, and I worked with individuals coming out of high school and transitioning into the workforce. And I started in 2007, and those kids didn't have this.
No, not.
They didn't have this. They were aging out of school and needed to go somewhere, and the parents had no idea what to do. So this is really meaningful to me that we're catching it sooner and they're getting this ahead of time, because my job was heartbreaking sometimes.
Yeah, no, definitely. And I've worked with adults at one point in my career also, and I look back and be like, man, I wish we could have gotten them earlier. From my own just observations, yeah, I think probably 5 years ago we were getting a lot of 4-year-olds, and now we're seeing significant numbers of those 18 months to 2 years.
Well, join me, please, in thanking Christy and Jessica for their presentation.
Thank you so much.
Thank you so much. So another topic that we certainly are all very focused on is emergency preparedness as we head into hurricane season, and thought it would be helpful if we had, again, a perspective from providers who are and have been over the last 2 years thinking about and becoming compliant with new expectations around emergency preparedness. And so we have invited Tracy Green with Southern Healthcare to come in and talk about all of the efforts to support our long-term care providers meeting these expectations around emergency preparedness. So Tracy, thanks for joining us. Thank you. Nice to see you.
So while I begin, we actually have a handout that's going to be passed around the room, and if there's not enough copies, it will be posted for you guys. So I think we only made 100 copies, and there's a room full of lots of you. So can y'all hear me okay? Am I holding this close enough? Okay. I'm definitely not a professional microphone user, so forgive me. So my name's Tracy Green. I am the Vice President of Operations for Southern Healthcare Management. I'm probably not supposed to tell you guys this, but my boss told me not to tell you what company I work for until the end in case I bombed. So, so forget that name unless it's really a great presentation, okay? I've been a licensed nursing home administrator for about 20 years. I started in nursing homes down in the Florida Keys eons ago. We got hit my very first year in the nursing home business. We had a hurricane come through the Keys, and I'm going to butcher this name because I don't know, it's been pronounced a million different ways, but Hurricane Georges, and I know that's not the way you pronounce it. I don't know if any of you guys were around back in '98 in South Florida. I see a few heads nodding. It didn't really affect, I don't think, the rest of the state, but it did cut right through the Keys. I believe it was only a Category 2, but we evacuated all 3 of our nursing homes down there to the federal prison in Key West. Was a brand new prison. Wasn't my idea, but down there, there's a lot of planning that goes on with the whole county because hurricanes affect the Keys probably in a different way than they do any other part of the state. But we spent 3 glorious days in a prison cell of sorts. It had bunk beds and toilets that all could watch you use at the same time. I've never been to prison except then. And that made me never want to go back. So I've been very well behaved since then. But, all of our residents were safe. Nobody got injured. And in all honesty, the Monroe County Sheriff's Office helped us out tremendously. It was a brand new prison. It was built to withstand a Category 5 storm, which is why we went there. The county officials helped us with all of that. And in the whole scheme of things, it went relatively well. But our plans have changed dramatically since that time, and we've definitely evolved in the nursing home business. I'm speaking to a room full of people who I'm sure heard the news, read the news 2 years ago when Hurricane Irma hit. It's kind of a taboo subject because of what happened, and it was a horrible story. But we took that story and have learned from it and grown from it. So I'm going to talk to you guys today about a few things. First, about generators. I'm sure you all have heard that we are all now required by law to have generators that can power enough air conditioner for 30 square feet per resident in each of our buildings. And that doesn't sound like a lot, but there's been so much that has gone into it. This law went into effect back in March of 2018, and we are still working diligently to comply with it, but it has been a real challenge. And I'm going to go over a few things. I wrote a few notes because generators are also not my area of expertise, but I'm somewhat familiar with what's going on, and hopefully I get this right. So we have 29 centers in Florida. Out of those 29, one of them had a generator that was big enough to power the entire building. So we had 28 centers in March of 2018 that we needed extremely large generators for in an extremely short amount of time. So we're a moderate, medium-sized company in the state of Florida. There are other companies that have, double, triple the number of centers that we have. And every single one of them, including many ALFs also, and there's way more ALFs than there are nursing homes, we all needed generators all at the same time. This made the generator people very happy. I should have bought stock in Detroit Diesel back in January of 2018, but they are working as fast as they can to manufacture all these generators, but it takes time. They're big machines, there's a lot that goes into it, and it's not just about manufacturing the generator. So I want to go over some of the steps that we had to take to get generators put in each of our centers. So the first thing we needed to do was hire engineers. They needed to come on site to all of our buildings that are spread out from one tip of Florida to the other tip of Florida and figure out what our current generators had the capacity to do and how big of a size of generator we needed to order in order to be able to power everything that needed to be powered in the centers. Once the engineer came out, he did the drawings, he gave us an idea of what we needed to order. We then needed to go through ACA to get permission from them and authorization saying, yes, this is what we need, this is what we're looking for. Once we did that, and once we got ACA's approval, we put the jobs out to bid for electrical contractors and equipment contractors. So, there's two sides that go into this. There's a manufacturer side, there's an engineering side. Again, I'm no expert on engineering, so I couldn't even begin to tell you what goes into all of that, but there's some genius people out there that know everything about power and generators, thankfully, and they have helped us out quite a bit in this process. So, just to let you know how long this is taking, out of our 28 centers that needed generators, 5 of them right now are up, running, ready to go. Approved by ACA. If a storm hit today, we would have full power for at least 96 hours with our new generator. So the other, the other 24 buildings, we are still in some part of the process of getting the generators. That's how long it's taking. It's not due to delays. It's not on our end. It's not due to not wanting to do it, because in the whole scheme of things, the generator rule is awesome. I can tell you firsthand, last year we went through some storms. We have 4 buildings in the Panhandle, 2 of which were affected by the storm because they had an influx of residents being moved into those buildings from buildings that were destroyed in Panama City. The other 2 were right in the disaster area of the storm. And the buildings were able to shelter in place because we had portable generators on site that could power all of the air conditioning. And in one case, we have a building in Bluntstown, Florida, and that building was the only building in a very large area that had any power at all for over a week. So it really helped us see how important these generators are, and I'm thrilled because I have worked for days and days in facilities that were without power after a storm, and it's hot, and staff wear down fast when they don't have AC. So we're still waiting, and we're in the waiting stages for quite a few of our generators to be fully up and running. So once we put the jobs out for bid and we chose our electrical contractors, we selected a manufacturer of the generator, which, as you can guess, is Detroit Diesel, and we put our orders in to begin making the generators. So one of the parts of the process that's taken the longest is permitting. And depending on what area the building's in, some of the permits only took like 2 weeks. It was quick, easy, and those are probably some of the buildings that currently have generators ready to go. We are still waiting for permits in some areas. And this is well over a year later, we still don't have the permits. I don't know where all of you guys live, but and I'm not going to call out any counties, but there's some counties that are very particular about their permits. So it is taking a very long time. In these cases, the generators are sitting on site, connected, ready to go, but we can't turn them on because we don't have permits. So that's kind of been a big struggle of ours. So as I previously mentioned, we experienced an extreme delay in production. All of the generators are what they consider to be level 1 generators. I had no idea what that meant, but it's called an HVHZ enclosure, which is what houses the generators, and that stands for High Velocity Hurricane Enclosure. So we had an option. We could either get the generators delivered in factory enclosures, or we could get a special enclosure that would protect the generator through even the highest levels of storms. And it would make no sense to spend hundreds of thousands of dollars on each generator and to have it wash away or stop working because we didn't get the higher level enclosure. So that also took a little bit of extra time. Once we knew what size of generator we would need at each center, while the generators were being made, we installed pads at each of the centers. We do have a few centers that were challenged for space. About 2 months ago, I was at a building that had already had a generator in place, and I was amazed at how big they are. They are really large, and we're talking 350, 400 kilowatt generators. I think it's kilowatt. I don't know. I don't understand all these engineering terms. Yeah, it sounds right. I'll pretend like I know what I'm talking about. They're huge, and in a lot of our centers, we're challenged. Some of the places that they're built are in cities, and the centers are built up because we don't have a lot of land to build out. So if you can imagine, we then have to find space to put this enormous generator on. And in a lot of those areas, people are very particular about noise. And a 350 kilowatt generator is very loud. So all of these things went into the process, and trying to make sure that we don't make our neighbors mad as well was part of the process. We also had to install new transfer switches. I didn't know what that was, but I am under the understanding that a transfer switch is what converts or makes the energy go from the main power source to the generator. And that's the simplest I can tell you, and hopefully that's right. And then we also had to have new fuel tanks installed, because along with the generator requirements, we also had a requirement to have enough fuel for 96 hours. So we need to be self-sufficient from an energy standpoint for that long. Now, I can tell you that a lot of our centers were out of power for longer than 96 hours over the last 2 storm seasons. But the goal there is, if we're out of power for more than 4 days, hopefully one of our fuel sources can get there to refill the tank. And if they can't after 4 days, we probably have bigger problems than that. So we also had to work with the Department of Environmental Protection. They are very involved in this process. And from the time, whenever we are ready to flip the switch and complete the project, we need to coordinate to have all of these people on site at the same time. So the Department of Environmental Protection has to be there, the manufacturer has to be there, the electrical engineer has to be there, and a representative from ACA has to be there. And all of those 4 people are on totally different schedules. And they don't care, the engineer could care less what the Department of Environmental Protection schedule is. So that's taken some coordination too. And I can tell you that we are very close to having this project finished in almost all of our centers. And I just hope that it's all done before the first storm hits. I'm a little nervous about it because it's so warm already. Summer is here. It came fast and quick. There was like no moving into spring. I guess that's Florida for you. But that's never good for hurricane season. So that's pretty much where we stand with the generator process. I can tell you I'm the chair of the Emergency Preparedness Committee for Florida Healthcare Association, and we talk about this all the time. So I am familiar with what a lot of other companies are going through, and we are not the only one who is still waiting at some stage in the process. A lot of companies are. But we are all working towards that goal, and honestly, it's really a wonderful thing to have in all the centers. So another thing I wanted to talk to you guys about is a new life safety requirements. A couple years ago, CMS published new emergency survey deficiencies that all centers in all states have to be compliant with. I can tell you in the beginning, it was a little bit of a mystery to us because some of the, we didn't really understand what the difference was between emergency tags on a federal level and what's called a CEMP, which is a Comprehensive Emergency Management Plan, which also has always been required. Those guidelines came out in 1994. And I understand that we're working on new CEMP requirements, but right now we're still operating off of what the requirements were way back then. So it's really been a learning experience for us, along with the surveyors. I can tell you I was down in Boynton Beach a couple weeks ago with a surveyor. They were going through an annual survey, and the life safety surveyor there was incredible. He spent 2 days with me teaching me everything he knows about emergency tags. So every time I get a chance to pick a surveyor's brain and learn about it, it's so helpful to me because I can see it from their standpoint. But basically, CMS wanted us to have more ownership over emergency preparedness. In Florida, we always think about hurricanes, right? I mean, I can tell you every building, when we plan a full-scale drill, 90% of the centers do it based on a hurricane because that's our biggest threat in this state. Unfortunately, in today's times, we're dealing with way more than hurricanes. Every now and then, I see a news story where there's an active shooter in a healthcare facility, whether it's a nursing home, a hospital, any kind of healthcare setting. That's terrifying to me because I do feel like hospitals are more hardened than our nursing homes are. Nursing homes, in a lot of cases, are people's homes. We have residents that live there. That's their house. And it's such a fine line between being intrusive on them, but also protecting them and making sure that they're safe. That's our number one goal. We have lots and lots of regulations to follow, resident rights. But what trumps everything is safety, and that's our job to make sure that they're kept safe. So active shooter is something that we've spent a lot more time on lately. It's unfortunate we have to do that, but hopefully we'll be prepared for that should it happen. Another thing that's really big right now is infectious disease. That's a new, that just got published actually this year, a new requirement to prepare for infectious diseases. Not your standard, I mean, we've always watched and prepared for infectious disease, but there's just so many other things now out there, and antibiotics aren't working as well as they used to. I'm not a nurse, again, but I listen to my nurses at work, and we have to make sure that we have policies and procedures in place to prepare for that. Bioterrorism, that's part of our security management plan. It blows my mind that that's something that we have to worry about in nursing homes, but we do. Bomb threats, we get those. It's crazy, but we get those. So these are all things that are covered in the new ETAG requirements. And again, we're still learning about that and trying our best to be compliant with it. And I think the surveyors are helping us with that also, thankfully. And then everybody's favorite topic, hurricane preparedness. So we, on June 1st, which is, 2 days from now, are going to be in hurricane season. Somebody just told me yesterday we already had a named storm. I don't know how I missed that, but that's nuts. So hopefully, hopefully that's the only named storm, but it probably won't be. And these things come in waves. So if y'all were in Florida in 2004, 2005, it felt like it never stopped. Especially 2004, I actually evacuated a building from Tampa to Winter Haven in 2004 because Hurricane Charlie was supposed to destroy Tampa, which I lived in for 13 years. Guess what? It didn't. Destroyed Port Charlotte. Came right up through Winter Haven. where we were. Tornado actually took the roof off of part of the building that we were housed in, which is where we thought we were going to be safe. So nobody got hurt, thankfully, but it was a very uncomfortable couple days until we could get back to Tampa, which was perfectly an okay building. So we have to be prepared all the time, but for hurricane season, we really ramp things up. And there's some steps that we take now to prepare in case a storm is headed our way. There's also a lot of last minute planning that goes on if and when a hurricane is close, but all of the things that we can do ahead of time, if we can get it done with now, makes us better prepared if one's heading our way. So a couple weeks ago, I think it was a couple weeks ago, I was down in West Palm Beach area for the governor's hurricane conference. He does that every year, and it's a great place where people from all different walks of life come. So basically there's emergency planners there, there's hospital associations there, healthcare providers. The trade show is awesome. All the vendors have like the coolest new things. That blew my mind too. Some of the things that they're selling nowadays for hurricanes is just great. Makes care a lot easier. So what we're doing right now is reviewing our transfer agreements with sister facilities and any other buildings that we have agreements with. We are required to have transfer agreements with other buildings in case we need to evacuate. Where are we going to go? I can tell you that some of the buildings that don't have sister facilities, so some of the nursing homes out there have individual owners and they're a standalone company. They don't have, 29 centers across the state. They're really having a hard time finding buildings to do transfer agreements with them because of the new generator law. So we're required to be able to keep 30 square feet per resident cooled for 96 hours in the event of a storm. And if all these facilities are still struggling to get their generators up and running, we have alternative plans to keep areas cool, but not enough if we brought in a whole nother facility into our facility. So we're lucky enough, we have transfer agreements with all of our sister facilities, but I know that is a struggle for some of the smaller company buildings. We also have a transportation contract with the bus line. We renew that every year at this time. They have evacuated many of our centers. They've always shown up. They've been very good to us, and we will continue to utilize them in future years. We send a letter out to all of our residents and their families to let them know what our plans are. It's not a real detailed plan, but we want them to know that we are ready and we are prepared if a hurricane comes. We keep plans throughout the building, so if any of them want to come and read the plan, it's always available there for them to see. We also check our supplies. We all keep a 7-day supply of food, water, medical supplies ready to go. And we have contracts with water vendors, pharmacy, any of the supplies. You guys would be amazed if you evacuate a center how much stuff comes with us. It takes numerous U-Hauls to get it all to wherever it is that we're going. We also check our, all of our centers have something to cover their windows with, whether it's shutters, plywood. We keep that stored close by, either on site or in a storage facility close by. And we have all of our maintenance directors check that at this time of year to make sure that the window coverings are still there and still viable and not rotted wood or anything like that. I don't know if y'all have ever tried to go to Home Depot when a storm's 2 days out, but there's no plywood available then. So we developed identification bands for our residents that have very specific information on them that we would use only in the event of an emergency. I'm actually reading a book right now called 5 Days at Memorial. Have any of you guys read that? If you are really into disaster preparedness like me, I know, I'm a nerd. I grew up in New Orleans. I lived there until I went to college, so I was there all of my growing up years. And Katrina, I was already gone when Katrina hit, but it hit really close to my heart because that's my hometown. And there's a book called 5 Days at Memorial. Memorial Hospital in New Orleans, the staff and patients were there for 5 days after Hurricane Katrina, and I won't go into what it's about or anything, but it's an incredible book. I've heard about it for years and finally decided to buy it and read it, so it's very interesting. But one of the things that they talk about is identification of residents, because in a real emergency, if a storm comes through and you have to quickly place people, like what happened in Panama City. You know, there's, 7 or 8 nursing homes that shut down after last year's hurricane season, and many of them were in the center when the storm hit. And the centers were flooded, destroyed really, and they had to very quickly find places for all of them to go. That's not the time to figure out how you're going to identify your residents. So we keep ID bands with certain information on it in the residents' charts so that if we do have an emergency, we can pull those out and put them on the residents quickly. We also have staff meetings. We talk to all of the staff, tell them what their roles are, as well as the department heads, because each one of them have very specific roles in the event of an emergency. And we want them to be educated and well prepared for that. So this isn't an all-inclusive list. Obviously, there is so much to do to get ready for hurricane season, but that's kind of a summary of it. Another great resource for us, Florida Healthcare Association, our association, and I'll put a plug in because I'm the chair of the committee, has done amazing things. I've been on the committee since 2004-ish, 5-ish, I can't remember the exact year, but we've come a long way in emergency preparedness. We've learned through every season best practices. I do feel like when we don't have a storm affect our state for like 10 years, we all get a little complacent and we think it's not going to happen to us again, and then we have the last 2 years like we had these last 2 years. And so it's a hot topic right now. I think the generator rules made it more of a hot topic. I think Hollywood Hills made it more of a hot topic. So regardless, we are going to be prepared and get prepared. Florida Healthcare Association has a website called, it's ltcprepare.org, that everyone, members, non-members have access to, and there are so many tools on that website to use to help nursing homes and assisted living facilities get prepared for hurricane season. As well as last year, in 2018, Florida Healthcare and its members did amazing things during last year's storm. They brought truckloads of donations to facilities that were affected by the storm. They gave cash to all of the employees in the center that needed it. There's pictures on the website of all of the donations they brought, and they really assisted us with helping to find placement for residents that needed it. We are ready. We will stay ready. And hopefully we will not have a season this year like we did the last 2 years, but if we do, we will continue to be ready. And if anybody has any questions, I'm happy to answer them. Yes, ma'am.
I know you said that you put the badges, you have the bracelets in the event of a storm to identify the patients, and that's a manual version of identifying. But what about the medical records that have to be immediately accessed upon transfer? How do you manage that?
Great question, medical records. So, and actually medical records are included in the new emergency tags that CMS released a couple of years ago. I will say that, and I'm throwing a ballpark figure out there, probably 90% of us have electronic medical records. So wherever we're evacuating to, we grant them access to those medical records, and it makes it so much easier because back in 2004 when we evacuated, it was paper charts and we had to bring them all with us. So some of these charts, you know, residents had lived in our centers for years, you know, they were that thick and you had to bring it with them because you didn't know if your facility was going to be destroyed and you couldn't leave it behind, you know. So electronic medical records has made it much easier.
Other questions?
Yes, sir.
Those electronic medical records, where do you house those records? Are they on the cloud? Do you have them on your computers at your facility?
You're really testing my IT knowledge now. Yes, I'm sorry. He was asking where are these records held? Are they in the cloud? So we have an office in Atlanta, and to my knowledge, and I could be saying this totally wrong, but there's a server there that houses all of the records. And there's backups of everything, and it's very important to make sure they're secure from a HIPAA standpoint, but they are accessible. We haven't had an issue with that. And I'm only speaking, of course, for our centers. You know, I'm sure each company has their own way of doing it. I hope that makes sense. Okay. Any other questions?
Oh, one in the back, last one.
$9 million. We had 28 centers that we had to buy generators for. He was asking how much we spent on them. It has cost our company $9 million, which was $9 million we were not planning on. So it's been a huge undertaking. A lot of that's the cost of the generators and everything that goes into it. But our company has also kept portable rental generators capable of powering the whole building at every one of our centers until the new generator's switch gets flipped. Because we wanted to make sure that we had the ability to power the center. And I can't tell you if every other company is doing it that way, but the expense of that is huge. Those portable generators aren't cheap. So it's a great thing. I'm not complaining. You know, it's a one-time cost, and once this is done, it won't be a recurring cost, but it is not cheap.
Tracy, I can't thank you enough. This is exactly what I was hoping we would have for a comprehensive presentation. I think certainly as it relates to the generator legislation and the rule, while we all agree, laudable, this is exactly the path we wanted to go down, I think what it demonstrates is that often what the policy looks like, the practical implementation of the policy, the challenges around timeline and local permitting are not always factored in, certainly with the urgency with which some of these legislative initiatives are adopted, rules are adopted. So this just helps, I think, provide a broader perspective for what we need to be thinking about, the questions we need to be asking as we entertain any policy. But I think what you also shared about the broader focus on emergency preparedness, the checklist. I had a chance to tour a couple of the hospitals in Panama City because there's both the planned and then there's the unplanned. You think you know until you don't. So how do you verify that you've trained your staff, you've anticipated every possible scenario? So I'm just incredibly impressed with not only what you shared, but the leadership of the Florida Healthcare Association. I know you've partnered strongly with ACA, and you've led. And really, that's what everybody wants to see. We may not have all the answers, but are we prepared to move forward and to lead and to identify opportunities and resources to support the entire system meeting those needs? So thank you, and thank you so much for everything you shared today.
We're happy to
We
be here.
appreciate it.
Thank
All
you.
right, thanks. Well, we're running a little behind, but we're gonna catch up because we've got a speed presentation coming up from James Kotis. Everybody know James Kotis? Well, James, that's your cue. You're gonna provide us with an entertaining legislative update. The bar is high.
I will jump it.
Okay.
Session came and went. Any questions? No, seriously. Less than 10 seconds is pretty good. No, yeah, session ended, came and went, ended on Saturday at around 2:07 in the afternoon. So while everyone was having a fun weekend, I was at the Capitol. So, but I just want to say, from my office, my first year working with ACA, thank you to everyone that helped with bill analysis, those questions that we got from staff and members, being ready. Your responsive time was incredible this year, and it did not go unnoticed. Got a lot of compliments from our committee chairmen, the staff directors, And it was a really good. It was really good. We have a really good working relationship with these staff members and members, and we're going to continue that going forward. So, what happened this session? I want to show this statistic to everybody because this is, I would say, the Florida House is very aggressive in filing legislation. So we out of 3,400 bills filed this year. I would say one of our biggest accomplishments with the governor's priority being the prescription drug, we were able to work with them and the governor's office and staff to get that bill passed. But I just want you guys to understand the work that you do and the timely response that you guys provide us really helps us navigate over there at the Capitol, because it's just every day, and we expect it going forward, that they are just going to continue pushing more initiatives, more reforms, and we are just, we're going to be prepared for that. So out of that 3,400, only 197 bills passed. That's about just under 8%, about 8% of all bills passed. And this is the current status of all 197 bills. Only 2 bills have been vetoed at this point in time. But June 30th is the end of the year, and with the governor and their delegation in Israel right now, we expect over the next 2 weeks a lot of the health care bills that got passed through the session and the general appropriations budget will be presented to the governor in the next couple days or the next week or two. So, really what happened this year? I broke it down into the kind of themes for to better help understand that state leaders are going to continue to drive major policy reforms. I've worked for 4 members before, so I've been around. I've worked in healthcare, and these are some of the themes that I just like to capture thoughts and the process into this area. In patient-centered reforms, healthcare access, healthcare delivery, improved outcomes, and what I'm calling disruptive policy initiatives. Best favored is Uber bill that we called it, but it's a reality. They are going to continue doing this, and we're going to adjust and move and respond to whatever happens. So some of the patient-centered reforms, prescription drug importation bill. Siobhan is going to talk to you more about that in depth, but this is one of the governor's top priorities this year. The ultimate goal was to allow an access or an option for Floridians to find lower cost prescription drugs. Speaker Oliva, one of his biggest missions is to increase access and quality services, as well as helping lower the cost of the healthcare system. So this is also one of his priorities that he worked on this as well. In HB 1113, what they call the Patient Savings Act, the thought about that, what you see in the state group, is incentivizing people to get more involved in making their healthcare decisions and choices. Like if I call Xfinity, I want to know I'm getting all my ESPN channels for college football. That's what they want. They want people to really look into what they're buying and what providers they're using. And health plans are getting more involved in providing incentives, rewards back to your spending accounts. So I expect to see more of that stuff going forward. With that, Paul Renner, he's a state representative out of the Palm Coast area. He's slated to be the speaker in 2021-22. He led the charge on this bill. He's been doing this bill for about 3 years now, and I expect to see him more actively involved and during his tenure do some more healthcare reforms in this area. Healthcare access. This was one of Speaker Oliva's top priorities of the year, is the repeal of Certificate of Need, CON. And it happened. I think a lot of people were expecting to see it happen next year, but this year we just saw a lot of things happen. And this one I would say caught the industry a little off guard. They've been preparing for this, planning, expecting this might happen, but I don't think they expected it to happen this year. Molly, if you think differently, let me know. And then on the bottom, A43, wouldn't be a legislative session if you didn't have one big omnibus healthcare package. This is just a few of the few of the provisions in the bill, it contained about total 13 different bills put into one. And all these bills passed, I should say, in one day. From the Senate to the House, all in one day. And I've been around, this was my 25th session, I've never seen that happen. It was before the last week of session too, so that was even crazier that happened. So, and then the final area, like what I'm calling the disruptive policy initiatives, we saw telehealth. That's been around since for a long time, but back in 2013, I know the Senate and the House started to kind of try and make this a priority, put some regulatory framework behind it. We are watching this. I know Governor DeSantis was also very interested in this bill. And finally, this year, there was some compromise done between the House and the Senate, and a framework and some definitions were given to this. So you'll see more about telehealth, I think, going forward as well. And then non-emergency medical transportation services. This is one of the, I know this is one of the first of a kind in the United States right now. This was big for the TNCs. And Uber and Lyft were very involved with this. Senator Brandis, who is the one who introduced Uber, broke the taxi cab regulatory framework up. He broke through that, and I think you're going to see more stuff coming from Uber and Lyft and other TNCs who are going to get into this world. How can they better fit into the healthcare arena? Because they see that as the future, especially with autonomous vehicles coming in. Everyone's kind of worried about their jobs as drivers and truck drivers. So, so that's it for 2019. 2020, though, is just around the corner. It starts in, committees will start in September, but this is what we're going to expect to see more of. They're going to continue to push more reform. The reforms will impact this agency. There's more disruption to come, and how will we move forward? And I just want to say with that comment and statement is your expertise, our knowledge of the system, our ability to see the trends and what's happening now, that's how we're going to make an impact, and that's how we're going to move forward from this with whatever comes our way from the legislature. So this is just kind of give you an idea. I know I'll be sending out a memo. We just got through one session. I'm going to need y'all to start thinking about the future, because September 16th is the very first committee week. And then session starts in 2020 on January 13th. That's it. Any questions?
Thank you, James. I'm sure there'll be more to come and more opportunity to grill James. So, Siobhan, we need to talk about importing drugs, prescription drugs. We are really making sure we put prescription in front of that phrase. Okay. Prescription drugs.
Okay. So first, let me say I want to thank all the speakers that went before me. I'm down to 5 minutes, and I love it. No, I'm just joking. So I will give you the Cliff Notes version. As James said, this past session, the legislature passed House Bill 19, and under the guidance and leadership of the governor and the Florida legislature, Florida is poised to be first in the nation to seek federal approval and actually implement a Canadian prescription drug importation program. So I'll talk to you a little bit about what the bill is trying to accomplish. So it has two parts. The first part is where ACA has lead responsibility, and that relates to the Canadian prescription drug importation program, where the agency would contract with a vendor who would help us manage and oversee the program, helping us identify eligible Canadian suppliers to export drugs into the prescription drugs into the United States, and then help us in terms of the relationships with the eligible importers. Those are pharmacists and pharmacies that are operating under several state programs, like the Medicaid program, working in county health departments through the Department of Health, the Department of Corrections, working with APD, licensed facilities, etc. So we have a lot of tasks in front of us over the next several months to implement the program. We will be initiating, or we actually have initiated a request for information on the vendor bid system to put out a, to get some information from interested vendors or stakeholders who have information on the costs that it would take to operate that contract, and then to collect information that will help us in drafting a solicitation that we'll put out there to actually secure a vendor for the program. We have to come up with the list of eligible drugs that will be imported into the state, so we're collecting information from the various state programs. Let me first say, one of the things that we had to combat all throughout session were questions around the safety and efficacy of the program and of importing drugs. I don't know if you guys know, but 40% of the drugs that you and I take today are imported or are manufactured in facilities overseas, outside of the United States. So we feel fairly confident that we'll be able to implement a very safe and effective program under this initiative. And so we need to identify the prescription drugs. We need to work with the vendor to make sure that we meet all of the safety requirements that are in the federal laws. We need to work with our federal partner, the Department of Health and Human Services, to seek federal approval. And so we're in the process of putting together a request that will go up to DHHS to seek that federal approval. And all of that is going to be done over the summer and fall. So it will be a very busy time. All right, that's it. Thank you. All right.
So let me just say, I want to commend Beth, Siobhan, the entire team in Medicaid that really has risen to the challenge. This is not an easy area, right? No one has done this. This is a law that allowed for the importation of drugs from Canada that has been on the books in Washington federally since 2003. The United States Department of Health and Human Services has not yet certified any program. They are supposed to certify to Congress that it is both safe and that it will produce significant cost savings to consumers. And for a host of reasons, some of which relate to turf and business concerns from the pharmaceutical industry, HHS has not done that. So I am so impressed with the team, because this is not, understanding the Food and Drug Administration and all of the policies and information around pharmaceuticals is not exactly something that is ingrained in the work that has been done historically here at ACA. So really impressed, because it was not about all the ways that we couldn't do it. It was problem solving. And that's why, as James showed how few pieces of legislation were passed, it is absolutely a monumental accomplishment that we got that bill through. Governor DeSantis, as you know, made this a huge priority, so I'm really grateful for the entire team for all of the work on that. So let's, a round of applause for everyone involved on that. And so we're going to round out our employee forum with a update from Beth Kidder on FX and where that effort is.
We have the slides ready? Slides? Maybe we don't have slides. All right, well, we won't have slides. I'll just dance instead. No. So Florida Healthcare Connections, or FX, we've talked about it a bunch, and you all just finished a survey, which I will talk about shortly. But just to remind you that what we're trying to do with Florida Healthcare Connections is really to transform the Medicaid enterprise to provide the greatest quality, the best experience, and the highest value in healthcare. No problem, right? That's going to be easy. And we have a lot of guiding principles that are talking about high quality, accessible data, talking about improving the recipient and provider experience. I know a lot of folks here are working on Medicaid provider enrollment to improve the provider experience of getting enrolled in Medicaid, just as an example. Reduce complexity. Our system is very, very complex. So these are just some of the kinds of guiding principles behind this project. Where we are right now in the project. It is a multi-year project. This will be going on. You'll be hearing about it for a really long time because it is transformation and it takes time, but also because instead of just once every 10 or 15 or 20 years, just replacing our management information system for Medicaid, this is going to break it up into pieces so that we'll probably continuously be updating something at all times. So where we are right now is building the infrastructure. We've talked about it before as the brain and spinal cord of the program, which is the ISIP, or Integration Services Integration Platform. That is the spinal cord. That is the piece that will send information and connect all the parts together. And also the brain of it, which is the Enterprise Data Warehouse. This is where we're going to get that good data and advanced analytics that will help us do our jobs better, target problem areas, get ahead of things, predict problems before they become an issue. So where we are right now with the ISIP invitation to negotiate is being negotiated as we speak. So we have a team that is meeting with vendors right now. They're going to take about 6 weeks to do that. So we've got a couple key people with information technology background that are sequestered in the other building working on that. And on the Enterprise Data Warehouse, we're getting very close to issuing that. That will come out this summer. So it is routing within the agency. We expect to have that out no later than July. So we will have another major invitation to negotiate on the street very soon. In terms of the change readiness assessment, so thank you all. This was a survey that we did. The Secretary started with a survey. I'm going to end with talking about the survey. 75% of agency employees completed the survey, so thank you, and give yourselves a round of applause on that everywhere. That's fantastic for a survey, and it is incredibly helpful to us to know kind of where everybody stands in terms of your readiness for this change. And this was 1,170 people responding, 89 different units represented, so really across the agency. So thank you for that. What we learned from this is a lot, but just a couple highlights. 77% of the people who responded said they want to know more about FX, and 63% of them want to know right now. So, and they really want to be able to plan for the future. So we hear that message loud and clear. We also heard from you all that almost everybody wants more information via email. So maybe they don't have time to come and sit through a presentation, but they do want to get information that they can read. So we'll be sending some things out. The next steps are that we're going to start doing FX email updates periodically to let you know where things are. Also, we'll be doing some in-person meetings in the bureaus. So as your bureaus are meeting, we're going to have people coming, talking, just doing a little bit of an update on FX so you can ask questions in a little bit more of a comfortable setting for you. Also, we have a portal page on this, and I was going to project it, but we will get these out to you. If you, we have an FX projects email, so it's fxprojects@ACA and the rest of the normal email. Also, there's a portal page. So if you go to the ACA SharePoint site, the portal, and you type FX in the search bar, the first thing that will come up says Florida Healthcare Connections. So we have a lot of information out there. If you're a person who likes to just kind of cruise through that kind of thing, you can take a look for yourself. But if you have questions in the meantime, email FX Projects, and you'll have more information coming soon on this. So thanks.
Thank you, Beth. Well, we did it. We got back on time. I want to just see any comments or questions as we close out at this point. Well, let me just ask, in terms of what we've been trying to structure for a format, for an agenda, do you like this? Is this helpful to have folks just get good? Okay. But truly, I mean this, if you have ideas, if there's someone that you've thought about either locally or regionally that might, again, help share some perspective of issue areas. When you think about the expansive role that we play in this agency, we touch so many different lives in different ways. There's so much that we can learn and gain from these kinds of presentations. Please don't hesitate to let me know. We're constantly trying to plan out for the next forum, so always interested in your thoughts and ideas. But thank you for taking time to be here today. We'll see you soon. Have a great rest of the week. Thank you.